Hello, my name is Maxim Abujude. I'm a PGY2 internal medicine resident from Canyon Vista Medical Center, and this is a case of CLL/SLL with a concurrent plasma cell dyscrasia. Now, I have included in my introduction the diagnostic criteria for both CLL and its variants, including SLL and monoclonal B-cell lymphocytosis, and the diagnostic criteria for multiple myeloma. However, I would like at first to present the case, after which, according to the criteria mentioned here, I will mention our final diagnosis. Now, this is a case of a 64-year-old gentleman with a past medical history significant for heavy alcohol use who quit back in 2020. The patient presented to our hospital complaining of dyspnea and bilateral lower limb edema. Upon evaluation in the emergency room, patient was noted to be short of breath. However, his vitals were stable and his O2 saturation was above 90% on 2 liters. Lab workup was significant for macrocytic anemia and lymphocytosis, and his imaging, which included chest X-ray and CT of the chest, showed cardiomegaly and the right-sided pulmonary nodule associated with right-sided pleural effusion. Now, the patient did mention that he was recently hospitalized in a neighboring hospital where he presented with similar symptoms and he was treated for heart failure exacerbation. He also mentioned that he was told that he might have a malignancy for which he needs to follow up on an outpatient setting with hematology and oncology. Now, at our hospital, during the admission, patient was treated for CHF exacerbation, and his workup included echocardiogram, which showed increased left ventricular wall thickness, strongly suggesting amyloidosis, with grade 2 diastolic dysfunction and pulmonary hypertension. Further lab workup was done to exclude other causes of his anemia, and at that time, our differential diagnosis included alcoholic cardiomyopathy versus AL amyloidosis versus ATTR. Patient did deny any recent alcohol use. Regardless, he was placed on CO protocol, however, he never had any significant scoring. Hematology were consulted due to concern for amyloidosis, and as per the recommendation, serum immunofixation and plasmapheresis were done, which showed high free lambda light chains and a low kappa lambda ratio. A follow-up with a bone biopsy showed plasma cell dyscrasia with lambda light chain restricted plasma cells consisting 10% of the bone marrow, a negative Congo red stain, and also showed lymphoproliferative process suggesting CLL/SLL. Bone marrow flow cytometry was also done, and it showed markers significant for lymphocytes and plasma cells. These markers included CD19, CD23, and CD5 for lymphocytes, and CD138, CD38 for plasma cells. Now, since patient's bone biopsy was negative and there was a high suspicion for amyloidosis, a file biopsy was done, which was positive for congruent staining. Patient's CHF symptoms were treated and was finally discharged from a hospital with a diagnosis of SLL, as he was found to have absolute lymphocyte count between 4,000 and 5,000, and he was found to have clonality for circulating B lymphocytes, which was confirmed on a flow cytometry. However, his anemia was not related to CLL and was never found to have lymphadenopathy, hepatosplenomegaly, or cytopenia. As for his plasma cell dyscrasia, patient's differential was multiple myeloma versus smoldering myeloma versus MGUS, as he never met criteria for multiple myeloma, which would include presence of clonal bone marrow plasma cells more than 10% of the bone marrow biopsy associated with end organ damage suggested by hypercalcemia, renal insufficiency, anemia, or multiple lytic bone lesions. So our final diagnosis for plasma cell dyscrasia was still indeterminate. Now, the patient was supposed to follow up with hematology in outpatient setting for further investigation and workup, which would include FISH, gene mapping, and PET scan in order to help us in determining his prognosis and his treatment plan. It would also include mass spectrometry or immunohistochemical assay of the fat biopsy or a pyrophosphate bone scan in order to determine what type of amyloidosis he has. Now, in my discussion, I included the criteria for treatment in CLL and multiple myeloma patient. And as we know, CLL patients mostly remain asymptomatic and do not require any treatment. However, there are criteria that would indicate treatment, some of which are obvious, such as developing progressive worsening cytopenia or symptoms secondary to mass effect of enlarging lymphadenopathy or splenomegaly. However, I would like to emphasize on one indication that is not mentioned that much, and is not that well known, which specifically includes a certain mutation, which is a 17p deletion TP53 mutation during FISH mapping. Now, the reason that this specific mutation is an indication for treatment in asymptomatic CLL patient is that there is a targeted treatment for this specific mutation with a good curative rate. As for multiple myeloma, all patients are treated. Now, before treating multiple myeloma, gene mapping and FISH testing is also required in order to differentiate high risk from low risk multiple myeloma and guide treatment and help determine if patient is eligible for bone marrow transplant. Now, having both CLL slash SLL and plasma cell dyscrasia is very rare. And while researching for similar cases, I would like to point out two interesting publications that I came across. Now, the first one is a study that was done in 2010 at the University of Freiburg, where they were looking into a single versus biclonal origin of these two malignancies when they coexist. Now, the study suggested that these two malignancies have biclonal origin, theorizing that the B leukemic cells would release factor that trigger the development of plasma cell dyscrasia. And the other publication is from 2016 from the American Society of Hematology meeting on hematologic malignancies, during which results of a retrospective analysis of clinical and treatment outcomes among patients with multiple myeloma and CLL were published and discussed. Now, around 10,000 patients with both multiple myeloma and CLL were treated, and they noted that CLL-directed therapy was not required, and all CLL patients responded to multiple myeloma treatment. In their research, they did not find any definite long relationship between both CLL and multiple myeloma. I do believe it is worthwhile to do further investigation into the possibility of a single or a related origin between both CLL and multiple myeloma malignancies, with potentially exposing more cases of CLL with underlying subclinical plasma cell dyscrasia, and potentially adding to the indications of curative treatment in CLL patients and hopefully improving mortality. Thank you.